Good evening. This is Dr. John Bennett, broadcasting from Miami. This is one of the broadcast series of Parkinsonism educational hangouts with Dr. Abdul Rana, a neurologist from Toronto, Canada, and a noted Parkinson's educator. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you this evening?
Very good. Okay, let's start in with the questions. What are the pathological changes in the brain of patients with corticobasal degeneration?
On gross inspection of these brains, you would see mild frontopalatal cortical atrophy. And these patients have abnormal deposition of tau protein. And the deposition of tau protein occurs in both basal ganglia as well as in cortex. The cortical tau neuronal inclusions are found in the pyramidal as well as non-pyramidal neurons, and they would make a perinuclear filamentous inclusions. These coil bodies, they appear as fine filaments and they are bundled together around the nucleus. The most diagnostic or most characteristic distinctive finding on these brains is the astrocytic plaques. These astrocytic plaques are the cluster of the distal processes, and their structure looks like a plaque. The amyloid filaments are not found in these plaques, but these tau inclusions or filaments, they are found in the glial processes. The tau inclusions in the glial cell processes may be seen in many other areas of brain, such as basis pontis, and this is different than progressive supranuclear palsy, in which the tau inclusions are mainly intraneuronal. The nuclear inclusions seen in corticobasal degeneration, they are antigenically and morphologically different from the glial cytoplasmic inclusions, which we see in multiple system atrophy. The substantia nigra in these patients may be depigmented, and but this depigmentation is much less obvious in those patients who have more cognitive impairment because they have more involvement of cortex. The neuronal loss and gliosis, spongiosis, and the subcortical myelin pallor is more prominent in the superficial layers of the cerebral cortex. In the more involved layers of the cerebral cortex, there could be more spongiosis, which sometimes is referred as status spongiosis. The gliosis in the subcortical white matter goes in parallel with the degeneration of the cortical neurons. The lateral thalamic nuclei, globus pallidus, subthalamic nucleus, and the nucleus basalis, amygdala, striatum, deep cerebellar nuclei, and other deep brainstem nuclei may be involved to some degree in these patients with corticobasal degeneration. The balloon cortical neurons, they have a pericardial swelling, and they also have the dispersion of the Nissl substance. There is loss of typical cytoplasmic staining, achromatria, and there are eccentrically located nuclei and cytoplasmic vacuolation in these neurons. The balloon neurons, however, they cannot be used to differentiate from progressive supranuclear palsy or from Alzheimer's disease. Some reports have suggested that corticobasal degeneration and progressive supranuclear palsy, as well as frontotemporal dementia, they could be a spectrum of one disorder because there is a lot of overlap of the clinical features in these patients. The tau positive astrocytic plaques are considered the hallmark of corticobasal degeneration, and to the extent that some of the researchers, they ignore the clinical phenotype of the disease, and they considered the astrocytic plaques sufficient to conclude a diagnosis of corticobasal degeneration.
Okay. What are the key diagnostic, Doctor, can you hear me okay? What are the key diagnostic features?
With respect to the diagnostic features, they are divided into two types. One is the core features, the others are the supportive features. With respect to the core features, the condition is insidious or gradual onset, but it does progress with time. There is no identifiable cause. The cortical dysfunction with at least one of the focal or asymmetric idiomator apraxia, alien limb phenomena, constructional apraxia, visual or sensory hemi-neglect, and cortical sensory loss. So apraxia of speech or non-fluent aphasia, focal or asymmetric myoclonus. So these are considered the core features. With respect to the supportive features, so these patients have focal or asymmetric atrophy on CT scan or MRI, which is maximum in the parieto-frontal cortex. There is also a variable degree of a cognitive dysfunction with the preservation of learning and memory. And these changes are subtle and they could be obvious on neuropsychological testing. The focal or symmetric hypoperfusion on the SPECT scan or hypometabolism on the PET scan could be helpful as a supportive feature. And this is also maximal in the parieto-frontal cortex. It could be seen in the basal ganglia as well as thalamus. There have been other criteria proposed by the various workers. There have been a criteria of the Office of Rare Diseases. That also has some core features. The core features, again, they involve the focal cortical neuronal loss, which is most prominent in the frontal, parietal, and plus minus in the temporal regions. There is a neuronal loss in the substantia nigra, and there are these tau positive neuronal inclusions, which are in the form of especially astrocytic plaques or threads in both the white matter as well as in the gray matter. They are most often in the superior frontal gyrus, superior parietal gyrus, pre and post central gyri, and in the striatum. With respect to the sportive features, in this criteria, the cortical atrophy, often with superficial spongiosis or tau-positive oligodendroglial coil bodies or ballooned neurons, which are usually numerous in the atrophic cortex. Because there is a great diversity in the clinical presenting features, so it could still be quite challenging to diagnose corticobasal degeneration, especially early on. In case of corticobasal degeneration, like progressive supranuclear palsy or idiopathic Parkinson's disease, the definite diagnosis or the confirmation is only by the postmortem examination.
Okay. Okay, doctor, how is this condition treated?
With respect to the treatment, since there is no cure and there is a diversity of symptoms due to many different areas of brain which are involved, such as cortex and basal ganglia. So the treatment is directed towards the symptoms, and it could be different from patient to patient. Also, the prognosis could be slightly different. There are no main core pharmacological treatments in these patients, which can delay or which can prevent the onset of disease, of course. With respect to the symptomatic treatment, these patients respond very minimally to levodopa, and sometimes they may not respond at all. With respect to the myoclonus, so in some cases, clonazepam could be tried. For the dystonia of limb, some experts do suggest using botulinum toxin, although this dystonia could be quite resistant to botulinum toxin. The other drugs, such as baclofen, steroids, anticholinergic, and anticonvulsants, which could be used in other conditions, they may not be helpful in case of corticobasal degeneration. For gait disturbances, physiotherapy, gait and balance training to prevent falls is very helpful. Again, the occupational therapy may help. May help decreasing the impact of the condition on the life of patient, as well as they could do the home safety assessment as well. Some reports have suggested using a weighted glove on the less affected limb, so that patients are encouraged to use the affected side. So in some patients, they might be helpful to reduce some stiffness or improve the use of the affected limb. Again, the speech therapy can help with dysarthria in some cases, dietitian assessment for dysphagia, and eventually some patients with swallowing problems may need the gastrostomy tube. So these are different things we try in these patients. The prognosis is their lifespan usually is between 5 to 7 years, although exceptions do exist.
Okay, very good. That pretty well wraps it up. Any no more questions? Is there anything else to add before we close on this topic?
I think it's a challenging condition to diagnose as well as to treat. The open discussion with the patient and the caregiver is very important. And if the diagnosis is not clear in the beginning and a physician suspects, I think then asking a movement disorder neurologist to help would be beneficial, not only in reaching a diagnosis, but also applying various treatment strategies which may help to improve the quality of life of these patients.
Very good. That wraps it up for this episode of Corticobasal Degeneration and Parkinson's. Thank you, Dr. Rana, and we'll be seeing you tomorrow night. And just a note for people, if they're watching, there is a YouTube channel on Parkinsonism TV and the website Parkinsonism TV. All these videos, all these educational hangouts that Dr. Rana and I have done are on that channel. So tune in. Okay, thank you, Dr. Rana. Good night.
Thank you, Dr. Bennett. Good night.
Yep, I just